Welcome to the Creative Commons RX podcast. Before diving into this episode, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
So today we're diving into what's essentially a high-stakes medical mystery. It's a rare but incredibly serious drug-induced neurologic emergency, and it goes by the name Neuroleptic Malignant syndrome, or NMS for short. So what exactly is it? Well, the official definition tells us it's a critical, though uncommon, emergency. But the two most important words here are drug-induced. This isn't something you catch, it's a severe, dangerous reaction to a medication. And while it was originally tied to older antipsychotics, we've learned that the list of culprits is actually a lot longer, which makes this whole thing way more complicated. All right, so here's how we're going to crack this case. First, we'll look at the classic signs of this emergency. Then we'll get into the main theory, what's happening in the brain. After that, we'll identify the triggers, piece together the clinical puzzle for diagnosis, and finally, break down how doctors manage the crisis. Okay, let's start at the beginning. At the scene of the crisis. When this emergency unfolds, what does it actually look like? Well, the clues are very, very specific. Doctors are trained to look for something called the classic tetrad, 4 key signs. First up, the patient's consciousness is altered. They can be anywhere from confused to completely comatose. Second, you see this intense muscle stiffness, often called lead pipe rigidity because it's so severe. Third, a really high fever kicks in, one that won't respond to typical fever reducers. And finally, the body's automatic systems, we're talking heart rate, blood pressure, sweating, they all just go haywire. When you see those 4 things together, that is a massive red flag. Now, the timing of all this is absolutely crucial. This isn't something that happens at a flash. It usually starts to build up over a week or two, after a patient starts a new medication or changes a dose. The very first clue is often a change in their mental state or maybe some of that muscle stiffness. But from there, things escalate fast, usually hitting a crisis point within the next 2 to 3 days. So we know what it looks like. But that brings us to the real heart of the mystery, the why. What on earth is going on inside the brain that could cause such a catastrophic chain reaction? And it turns out, for all its complexity, the case really boils down to a single primary suspect, the neurotransmitter dopamine. The leading theory is something called dopaminergic hypoactivity. Now, the easiest way to think about this is like a sudden, massive power failure in the brain's dopamine circuits. These circuits are responsible for regulating movement, controlling body temperature, and our thought processes. So when that dopamine signal is suddenly blocked or shut down, all of those critical systems just crash. And the evidence for this theory? It is incredibly strong. I mean, think about it. Every single drug known to cause NMS blocks dopamine. If you suddenly stop a dopamine-boosting drug, like for Parkinson's disease, you can trigger the exact same syndrome. And the final nail in the coffin? One of the main treatments is to give a drug that restores dopamine activity. It's a pretty compelling case. Okay, so we've got our mechanism of action. Now let's bring in the suspects. What are the specific drugs and situations that can actually pull this dangerous trigger? The highest risk offenders are the older, first-generation antipsychotics. The newer ones have a lower risk, but it's definitely not zero. But here's the plot twist. It's not just antipsychotics. Even some very common anti-nausea medications can trigger it. And, like we just said, abruptly stopping Parkinson's meds can do it too. This really widens the net of who could potentially be at risk. So just how common is this? Well, while the consequences are obviously devastating, the syndrome itself is pretty uncommon. When you pull all the data, the estimate comes out to about 2 cases for every 1,000 patients treated with antipsychotics. It's rare, for sure, but common enough that every single clinician has to keep it on their radar. And this brings us to the really tough part, the diagnosis. You've got a wide range of triggers and a set of symptoms that can look like a lot of other bad things. So how do doctors put all these pieces together? especially when they're under incredible pressure. And this is absolutely critical. There is no single blood test or scan that can definitively say, this is NMS. The diagnosis is pure clinical detective work. It relies on getting a really detailed patient history, especially about medications, a sharp physical exam, and maybe most importantly, just having a high index of suspicion in the first place. Now, one of the trickiest parts of this puzzle is telling NMS apart from its clinical doppelganger, serotonin syndrome. Getting this right is a huge deal. NMS tends to have a slower onset over days with that really unique lead pipe stiffness. Serotonin syndrome, on the other hand, hits you fast within hours and is known for causing twitching and super active reflexes. Now, even though there's no single diagnostic test, the lab work can provide some massive supporting clues. The biggest one by far is a sky-high level of an enzyme called creatine kinase, or CK. We're talking levels often over 1,000. This happens because that intense muscle rigidity literally causes the muscles to break down and release CK into the blood. It's not a smoking gun on its own, but it's some pretty powerful evidence. So, the diagnosis has been made. The clock is officially ticking. And now it becomes a desperate race against time to manage the crisis and pull the patient back from the brink. The treatment plan has to be clear and immediate. Step 1, stop the drug that's causing the problem. That is the single most important thing you can do. Step 2, start aggressive supportive care. This almost always means a trip to the ICU for intense monitoring, cooling measures, and IV fluids. And step 3, bring in the specific medications, the antidotes to counteract what's happening. The pharmacological toolkit here is really specific. You have 3 main players. First, a drug called bromocriptine, which works to directly reverse that dopamine blockade at the source. Then you have dantrolene, which is a potent muscle relaxant that helps fight the rigidity and bring the fever down. And finally, you have benzodiazepines to help control agitation and add another layer of muscle relaxation. But even after a patient makes a full recovery, the danger is not entirely over. And this next number is pretty staggering. There's about a 30% chance that NMS will happen again if an antipsychotic is reintroduced. That's a huge risk that changes everything about future treatment plans. Because that risk is so high, preventing another episode becomes priority number 1. If a patient absolutely has to go back on one of these drugs, clinicians have to be incredibly careful. We're talking waiting at least 2 full weeks, choosing a drug with a lower risk profile, starting at the absolute smallest dose possible, and then increasing it very, very slowly, all while watching like a hawk for any of those early warning signs. And that really brings us to our final thought here. NMS was first discovered because of older medications, but we are constantly developing new and more complex drugs that mess with the brain's dopamine system. And as that list of drugs grows, the list of potential triggers for NMS grows with it. So it leaves us with a really critical question for the future. How will our clinical skills and our vigilance have to evolve to keep pace with this rare but absolutely deadly medical mystery?
This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.